Here's where we need to start, but first, where are pencils made? Pennsylvania, nice job. Who is that? Well, that's a good sign for the exam. You're about ready for the exam, I'd say. Who earns a living by driving people away? Who said it? A taxi driver. Man, there's be some serious A's on Monday. This is good karma right here. Nice job. Of course, the questions will be quite different, as you know, because there'll be some other options to choose from besides a taxi driver. You know, could be a cab driver, A and B only, for example. Ooh, that was a sore subject, wasn't it? So I didn't mean to push a hot button there. Just trying to make a joke. Here's where we got to start. Yes, sir.
Do osteoclasts eat both spongy and compact bones?
Yeah, osteoclasts don't discriminate between the different types of bone. The other thing in SI, if you did that worksheet and it's ready to turn in, that's wonderful. You should bring it to SI because you're going to need to know answers to those worksheet questions. What worksheet am I talking about? That was the homework I assigned on Monday. So go to SI, they will have the answer key, and that'll be a leg up on the exam, for sure. Okay? You remind me to get you the answer. Okay. So we need to talk about this question, this ultimate question, are bones static in adults? We talked about embryonic development of bone. We talked about two main types embryonically. What were they? Intramembranous, a bunch of membranous, and endochondral. Which one goes which? Which one goes where? What's an example of a bone embryonically that's developed using intramembranous ossification? Flat bones like bones of the skull. And what's an example of bones that develop embryologically via endochondral? Long bones. Okay, short bones as well. We kind of focused on the long bones, but I hope you put the long bones and the short bones in the same category. Then after you're born, everything changes. You're on your own, you have to breathe, okay? You have to process your own waste products. And now your bone develops under different methods. And what did we call those? The interstitial growth was what? Like, yes, you're on the right track. It's like which one? It's like. We got like so far. It's like long bone development, which was endochondral ossification. So interstitial growth adds new bone in length, and the other name after birth is called what? Appositional growth, and appositional word means what? Diameter or size or girth, okay? The width of the bone, the density of the bone. So this question, are bones static in adults? Absolutely not. Even after all that happens and we close our growth plates, we still get remodeling of bone. And that's one of the big themes of this last lecture. This all occurs via a process known as Wolff's Law. Julius Wolff was a German anatomist, and he made observations that we're going to talk about in a second, but he basically said this, that osteoclasts and osteoblasts are in a balance, in a healthy environment. And bone itself is going to remodel or change based upon the force or stress that it's placed under. So if you have bone that's under weight bearing, you're going to favor osteoblasts and build new bone. If you have bone that's not being loaded, like a bed rest patient or a patient in a wheelchair, you're going to see osteoclastic activity dominate, and you're going to get decreasing of the density of the bone. Okay? If you also get out of balance, you see some disease states, and we're going to talk about osteoporosis here momentarily. Let me just finish up Julius Wolff and I'll take your question. So, a while ago, 1836 to 1902, he made a lot of observations during his time as a surgeon in the Franco-Prussian Wars, okay, for those of you that like history. And he published his theories, and this theory was translated in the mid-90s, or 80s, 1980, from an original publication in 1892. So 1892 is well before we knew a lot about bones. It's well before we put anybody in space. And he actually was making some theories even about space back in 1892. And so what he was saying is that a healthy person or an animal is going to modify or adapt its bones based to the loads that it's placed under. Furthermore, if you have this classification of bone resorption, this means that there's a response to a decrease in stress. And osteoclasts will dominate that activity. Where you're going to see bone resorption, or bone going away, because osteoclasts are digesting it, is in things like disuse or immobilization. If you cast the bone, or if you put the patient on bed rest, okay? And then he also made this theory about microgravity. If you were putting an individual in a low gravity situation, like in space, you would see bones resort. That's exactly that's one of the main problems we have with astronauts that come back. This is in 1892. This was a bright dude. Okay? To finish out what he said, the other option is deposition. He favored laying down new bone. This is a response to an increase in stress. Osteoblasts are the cell type that dominate because they lay down new bone. And weight-bearing exercise is an example of where you would see this. This is one of the reasons we like to prescribe for patients that are in their senior years, especially postmenopausal women and older men, and we'll talk about that more today. We want you to do, Mrs. Smith, weight-bearing activities. This is why, because this makes the osteoblasts stimulated in their bone, and they're going to create needs to increase the density of the bone, and you see appositional growth. Question?
Yeah, does that mean that by lifting heavy weights and stuff like that, like will your bones get significantly bigger or just like a little bit?
Well, you may not see it visually of thicker bones, but microarchitecture is going to change. The density, if you were to take a cross-section through the bone, or if you took an x-ray, you would see a denser quality of bone with weight lifting or weight-bearing activity.
But do they grow in diameter maybe just a little bit?
Maybe a little bit, but probably not really all that observable.
Okay.
It's mostly the inside density, the architecture. Okay, if you look at the inside makeup, it's going to be a denser material, even though it's the same size.
So lifting weights and pushing things doesn't just help your muscles grow; it helps your bones get stronger.
That's correct.
Amazing.
And it makes sense too, right? It is amazing because if you build muscle and you increase muscle weight, you want the bones to be able to respond to that weight. So the structure has to be there to accommodate. Yes?
So like, how does this relate if you broke a bone? The part of the bone that healed, that just becomes stronger than the
Yeah, hold that question because I have a slide on that. Okay? So here's some evidence that bones remodel. Okay? This is some evidence that bones remodel. These aren't my kids. They were like way cuter than that. But every parent thinks that, right? I don't think newborns are really all that cute, except for your own. Usually, you see other people's go, ooh, so cute. Wow, right. Can't you like wipe it off at least? But your own, you're like, oh my gosh, it's so adorable. Looks just like me, right? All right. So when we're born, our spine is in this C-shaped curvature. Okay? And as we develop our secondary curvatures, because that primary curvature is the C-shape, developmentally you start lifting your head first, and then you start crawling and lifting your head, right? And that actually puts stress on the cervical region, the neck, and that creates that curvature in the neck region. The curvature meaning that if you look at the bone, there is a curvature as this individual lifted their head, and the spine goes from a C shape and starts to take that turn in the cervical region. Then the next milestone of the lumbar curvature actually happens when? When you start walking. And as you start walking, you're putting stresses in different ways across the vertebrae. And so those vertebrae actually respond and you get that curvature, that lumbar curvature, later in life when you're walking. So here's evidence that our bones do remodel. Further evidence that we have of remodeling of bones is an example of inactivity. If you have bed rest of a patient, you lose a mass of about 1% per week. You may not visibly see it. You may not see the bones actually physically change in shape or size, but the density on the inside actually changes. That decreases the moment of inertia. And remember, that moment of inertia is a statement that means the resistance to bending. So a lower moment of inertia, meaning a less of a resistance to bend, means a weaker bone. A 20% decrease in the diameter, okay, if it does shrink in diameter, is a 60% reduction in torsional strength. Okay, so you don't have to lose much. 20% decrease in the diameter, you might not even see. I mean, an expert, a radiologist might be able to tell, but you and I probably wouldn't be able to tell that. You wouldn't be able to see it visibly on an x-ray. It wouldn't be that obvious, a 20% reduction in diameter. Okay, but an expert would actually see it. What's happening at the microarchitectural level is we get this demineralization that takes place. This demineralization, and this is what I was referring to. This is the microarchitecture of normal bone on the left, and then the architecture of demineralized bone, or bone that's actually been remodeled under less stress. And that's a more open, less dense bone. Okay? So a loss of calcium in osteoporosis as we get older is one of the resulting problems, and that's an osteoclastic activity that's dominating. Some other disease states that are listed here: osteomalacia, as it's referred to in adults. And in children, the disease is called rickets. This is due to a decrease in vitamin D availability, or a vitamin D deficiency. Now let's connect some dots here. Rickets in children, or osteomalacia in adults. When would that be a problem where maybe vitamin D availability is compromised?
Do you live in a really cloudy place with no sunlight?
Cloudy environment with no sunlight. Okay, you're not getting a lot of sun exposure. I totally agree. Why? What's the next step? Mechanistically. What's that? Phosphoric acid. How's it connected? It's not where I was going, but that's fine. That'll work. You can get there from there.
If you have vitamin D deficiency, you're not absorbing as much calcium.
You're not absorbing as much calcium if you have a decrease in vitamin D availability. And what organ is responsible for starting this catalyst where you take cholesterol, you expose it to sunlight, and then you convert it into a format that's a vitamin D precursor? What organ gets that going? The skin. Okay? And then the skin sends that precursor to the liver, right? The liver sends that next intermediate to the kidney, and now you have calcitriol, which is the most active form of vitamin D. Remember that? So the most active form of vitamin D is calcitriol. The skin doesn't make it. You have a couple of organs along the way that help out, but the skin gets it started. And that activity of calcitriol, active form of vitamin D, prevents calcium from being excreted in the urine. It prevents calcium from being lost in fecal material. And it encourages your gut to absorb calcium out of your diet. So that's, again, why we purposefully put skin and bone together in this particular unit. So if you have these deficiencies in adults or in children, you can get some rather aggressive deformities, okay, as the bones grow. Yes?
So people who are lactose intolerant, are they more prone to get osteoporosis because they're not taking as much calcium?
Possibly. And let's wait until the later part of the lecture where we start talking about the risk of osteoporosis. And that'll help answer your question. So you two are going to have to remind me that I turfed it till later. Okay? So, maintaining bone homeostasis. Well, 5 to 7% of your bone is recycled every week. In fact, the head of your femur that you have today is different than the one you had 6 months ago. You built a new femur in 6 months. Probably for you all because you're young and healthy, it was probably more like 5. Happens, and you're active. Okay, college students tend to be active. If you're active and you're playing intramural sports or recreational sports or competitive sports, then that femur is turning over much more frequently. The use determines the rate of replacement, and that's what that means. For you all, it's probably a little faster. It happens at both ends of the bone, the inside, the endosteum, as well as the outside, the periosteum. When bone remodels 5 or 6 months from now, right, you'll have a totally new femoral head. The bone is first dissolved, and then you get deposition of new bone. The osteoclasts secrete what? What do they secrete again? Osteoclasts, what do they do first? They break down bone, so they're going to have to secrete 2 main components to break down bone. One that digests the collagen, which is the organic component, and that one's what? Sounds like a taste. Starts with acid, has a phospha in it. Acid phosphatase, very good. Wow, you guys are brilliant. Acid phosphatase digests the collagen. And then the other one, hydrochloric acid, I didn't need a hint, and that digests what? The inorganic component, which is the minerals. Very good. Okay, so the osteoclasts secrete acid phosphatase and hydrochloric acid we talked about in the previous lecture. I'm just giving you some hints that you should probably look at that again before Monday, for example. And they excavate a tunnel, and that releases calcium as the osteoclasts digest away the bone. Now, the osteoblasts enter the tunnel, and they secrete the matrix. So you recycle it because you want to have fresh bone, and you want to make sure that nothing becomes really stale, in a way. Okay, and you can see this picture of this histological view. Here's our osteoclast. You know it's an osteoclast. Why? Give me some reasons why you know that's an osteoclast. Because it's labeled there, Dr. Keller. Duh. Okay, well, Monday it won't be. What's that? Multiple nuclei. You see the multiple nuclei?
Yeah.
Those are those darker purple towards the back, and on the front leading edge is what we call the ruffled border, right? And that increases the surface area to crank out these digestion enzymes, chewing away the matrix. As the osteoclasts chew away the matrix, now we run into the situation of calcium balance. And this is why this happens. So some students are like, why do you recycle it every 5 to 6 months? Well, because you need a source of calcium. So it's kind of like you always need the faucet running. It's not necessarily the most efficient way to do it, but it means that you have a constant flow of calcium in the blood under a homeostatic, balanced level. But in order to do that, you have to have cells at both ends chewing up bone to release calcium, and the other one using it to lay down calcium. That keeps the level relatively stable. Okay? Under certain circumstances, you say, you know what, I need to turn the faucet up because we need to build some bone here. Or I need to slow the faucet down because we're not doing a whole lot of weight-bearing activity, and so there's no reason to spend the energy building bone. So if you look at these 2 charts, important charts, busy charts, but let's take them one at a time. Calcium levels are monitored very carefully in the blood, and 2 main organs help do this, parathyroid and thyroid. These are endocrine organs that you'll look at next semester in 202 in further detail, but we do need to talk about it here because they play a role in bone homeostasis.
I thought that thyroids regulated your desire to do things also like eat and sleep and go to the bathroom. I didn't think they were for calcium monitoring. I thought they were also for...
Thyroid also makes metabolic hormones like T3 and T4, and then the one that you're thinking about is up in the brain, and we're going to talk about that in the nervous system.
Okay, so this is all the thyroid does?
No, thyroid does a few things, but this is what the thyroid does as it relates to our needs today.
Okay.
Okay, and for Monday. Okay, so the thyroid releases calcitonin, but first off, let's look at this. Thinking about calcitonin. If you start up here and you have blood calcium levels are too high, you're going to stimulate calcitonin release by the thyroid. Calcitonin has activity on osteoclasts to reduce their activity, say slow down, stop chewing up bone. Calcitonin has activity on osteoblasts saying go build bone and use up calcium. So both of those activities mean you have less bone resorption, you have more bone deposition. That leads to blood calcium levels going down. Make sense? This is an example of a negative feedback loop, right? Because the response to the problem state is in the opposite direction. The problem is the blood calcium level is too high, so you trigger calcitonin secretion by the thyroid. That activity ultimately lowers blood calcium levels. Classic example of a negative feedback loop. Remember the feedback loops? Remember how I said these things could be cumulative? There's a great example of cumulative-like material. Okay? This one's a little bit more complicated, but not much. This one is what happens if you have, so this would be considered hypercalcemia, too high. Hyperactive children, hypercalcemia. Okay? Hyper, I'm not saying hyperactive children are hypercalcemic, I'm just saying hyper, okay? Hypo, this word means too low. Hypocalcemia. So you start here in the upper left, you can circle this, say start here. Circle this, say start here. Too low blood calcium. You stimulate parathyroid hormone secretion, that's what PTH stands for. This has 4 activities. It increases osteoclasts. That should make sense. It reduces osteoblasts. That should also make sense, if you think about it. It allows for more phosphate excretion in the urine, meaning that you don't have a lot of precursor hydroxyapatite to make bone. So you lose one of the starting ingredients to make bone. Also, you decrease the amount of calcium that it excretes. So you excrete phosphate and you conserve your calcium. If you do this, now you conserve calcium, you free up calcium. All of those lead into the response to the problem state in the opposite direction. Again, you increase blood calcium levels to normal. So that's an example of what kind of feedback loop. Negative as well, right?
But I thought that phosphate was also important for other things, not just making bone. Isn't it also part of the DNA helix too?
Yeah, but this is actually within the bloodstream, not necessarily within the cell. So the blood levels of phosphate are changing.
Phosphate is very important for DNA helix and to phosphate your dead.
Yes, but you wouldn't get rid of all of it, and you don't strip the cell of phosphate. Okay? So why do we care? Well, here's why we care. You have some very impactful sequela. That's a fancy word that means clinical result. If you're too little, hypocalcemia, you got the excessive excitation of nerves. You have what's called a carpal spasm, which is what's shown in this picture. You'll get spasm of muscles, and you could, unfortunately, have what's called a laryngospasm of that muscle. And so you cannot necessarily relax it. And that could be very, very dangerous in the throat. Also, if you have too much, which is more rare, you actually have less excitable nerves and muscles. You get muscle weakness and sluggishness. And you could have cardiac arrest. Right? Cardiac arrest because you're not stimulating the muscle, the cardiac muscle, to actually be firing. So the picture here is a carpal spasm for the top example. And the bottom one of hypercalcemia is too much. That's a much more rare condition because you usually regulate too much very carefully. So that wraps up this particular lecture.